Good evening, everyone, and thank you for joining us for another CME event sponsored by Wilson Children's Hospital of Jacksonville, Florida. It is our pleasure to bring you this evening's presentation and trust it will assist you in providing the best care for your patients. I am Dr. Michael Gale, Medical Director of Outreach and Transport at Wilson Children's Hospital. I will be moderating this evening's presentation, and I will be assisted by my two co-hosts from Business Development, Faith Galloway-Sisoto and Sonny Kapadia. The mission of Wilson Children's Hospital is to promote optimal health for all infants and children we serve. Wilson achieves this mission by providing patient and family-centered care, education, research, and by advocating for children. Wilson Children's Hospital is located in Jacksonville, Florida, just where I-95 and I-10 intersect, for those of you who need some identification of where our hospital is located. In order to serve the patients and families in the referral regions of Florida and Georgia, Wilson Children has developed a network of satellite specialty clinics in our referral regions, as shown on this map. Our speaker this evening, Dr. Vining, is a full-time pediatric cardiologist in practice in Tallahassee, and also goes to our Valdosta clinic twice per month. Before this evening's program begins, we should give you a few information about our housekeeping, some housekeeping items that we want to go over. To ensure the best sound quality throughout the program, all attendee microphones have been automatically muted to reduce background noise. We have reserved the last part of the program for Q&A. Please feel free to submit questions during or after the presentation. To submit a question, simply use the Q&A feature at the bottom of your screen. I just wanted to remind the viewers that Wilson Children is a accredited pediatric trauma center, and the number for our referral is shown on the screen. Our presenter this evening is Dr. Justin, otherwise known as Mac Vining. He is the medical director of Tallahassee, our Tallahassee Outreach in Pediatric Cardiology at the Wilson Children's Hospital Specialty Center. Dr. Vining attended college and medical school at the Medical College of Georgia in Augusta, Georgia. He did both his pediatric residency and fellowship in pediatric cardiology at Children's Medical Center at the Medical College of Georgia. Following his fellowship in pediatric cardiology, Dr. Vining took a position as an assistant professor in pediatric cardiology at the Children's Hospital of Georgia at Georgia Regents University in Augusta, Georgia. In 2016, after a few years of practice in that position, Dr. Vining subsequently took a position at the Wilson Children's Hospital Specialty Care Center in Tallahassee. Dr. Vining has been practicing pediatric cardiology for over 6 years and is the only board-certified pediatric cardiologist in the Tallahassee area. He is a very well-respected cardiologist and has given numerous lectures on pediatric cardiology topics in several locations in Florida and Georgia. As I said before, he's in full-time practice in pediatric cardiology in Tallahassee, and also goes to Valdosta twice per month. This evening, Dr. Vining's presentation will be, it starts with the right question, addressing the topic, 3 most common pediatric cardiac conditions. My pleasure to introduce Dr. Vining.
Well, thank you, Dr. Gale. Now hopefully everyone can hear me and can see my screen. If not, just let me know. I'm still a bit of a novice with Zooming. I'm used to doing these things in person, but apparently, according to Faith, we have so many people that RSVP'd for this. I'm starting to think that maybe this is the way to go. So as Dr. Gale said, I appreciate that introduction. I promised him I wouldn't say anything bad about the Clemson Tigers because they're playing Georgia in the first game next year. So obviously, you know who I hope wins, Dr. Gale. Hopefully I've met many of you before, face-to-face, if not. As Dr. Gale said, I am from Georgia. I've been in Tallahassee here for 5 years, helping build the Wolfson Specialty Center here in Tallahassee. I'm very proud of what we've been able to accomplish in the past 5 years here, including going to Valdosta, We recently expanded that clinic to 2 times a month, like he said. And I feel like it's been very successful so far. And we have a lot of exciting things coming up, specifically related to Tallahassee with the Wolfson Specialty Center, as far as different subspecialists and locations and things. So just stay tuned. Faith has all the information on that. And I'm sure she'll be touching base with pretty much everyone going forward. So with that being said, I just wanted to talk briefly tonight, I won't keep you too long, about a few things that I see very commonly each week, and a few things that are near and dear to my heart, and actually some current events. So we'll talk about 3 of the most common things that I see in my office on a weekly basis, many of which I probably actually saw today. Here are the goals and objectives for tonight's talk. We're going to talk about some of the most common chief complaints that you may see in a primary care setting that may require a pediatric cardiology referral. Review some of the common presentations and histories that go along with those complaints, and briefly review what I typically do for patients when they come to see me in the office. This is the scope of practice for pediatric cardiologists. Many people hear the exciting things or all the things that get most of the attention. That's typically congenital heart disease, cyanotic, and sometimes acyanotic congenital heart disease. But in reality, that's only really about 1% of what we do, probably. A lot of it is really non-cardiac things that we have to rule out. So less commonly acquired heart disease like valvular heart disease, fetal cardiology and echo, which is something that we hope to have up and running here in Tallahassee very soon. We have all the groundwork here for that, just moving forward with it. Genetic syndromes. Many people don't realize that about 50% of genetic syndromes also have associated congenital heart disease. So that is one of the most common things that has to be screened for in any kind of baby or child that has a genetic problem. Electrophysiology and arrhythmias, quite common, and I have a very great working relationship with Dr. Ferns over at Wolfson Children's Hospital, who's an electrophysiologist there. Her and I talk on a weekly basis, if not sometimes daily, about patients and referrals and getting patients over there for studies. Chest pain, syncope, and sudden cardiac death, which is extremely common thing that we have to look for and rule out during sports seasons like football and basketball. And ironically, this is becoming a very common question right now with COVID-19. Athletic clearance and fitness, which is the same exact sort of topic. Hypertension and hypercholesterolemia, this is becoming to be a bit of an epidemic in the pediatric community. 25, 30 years ago, there were very, very few children that had hypertension. Normally they had some sort of renal or organic issue that would cause that. Now a lot of it is environmental and related to body habitus, and hypercholesterolemia goes along with that. A lot of cardiologists really don't see that. That's typically referred out to either nephrology or endocrinology, but here in Tallahassee, I've taken that under my umbrella and actually have a fairly sizable clinic of patients with pediatric hypertension. And then also the exciting stuff that I personally get excited about, which is the post-operative care of surgical patients who have had their surgery at Wolfson's. Dr. Shillingford and his colleagues over there do a great job. They always keep me well informed on how my patients are doing when they go over for surgeries. And then they have all their follow-ups right here in Tallahassee with me. So some of the most common chief complaints that come across our office each week, by far the most common is heart murmurs. And in your own practice, if you're primary care, this is probably one of the more common things that you think about referring to a cardiologist. But also we get asked lots of questions that essentially we need to assess heart function. So any patient who has syncopal episodes or dizziness, or if there's concern about arrhythmias, patients who have had chemotherapy in the past, any of those things for which a patient needs an echo basically to determine their heart function. Arrhythmias as well. We get EKGs on all of our patients. There's some screening programs. In particular, there's one that I'm affiliated with called SafeBeat, which sometimes goes into the schools and does EKGs. So we get a fair amount of referrals from those patients as well when they have abnormal EKGs. Cyanosis, which obviously is much more common in babies. Genetic syndromes, like I mentioned earlier. Chest pain, although it falls a bit lower on this list, I actually feel like I see chest pain quite a bit more commonly than just 5% of the time. So it is one of the topics I'm going to talk about tonight. And then syncope and dizziness, especially in athletes, always a concern and something that we need to rule out heart issues with. And then a few less common things like endocarditis, Kawasaki's, and pulmonary hypertension. This would be sort of a typical run-of-the-mill new patient consultation in our office. Patients usually after registering will be brought back. We'll get full vitals, including what I call the fifth vital sign, the oxygen saturation, and upper and lower extremity blood pressures, which can be very important. For instance, today I had a baby who had surgery at Wolfson's for a coarctation repair a little less than a month ago. And so in a patient like that, it's very, very important to get upper and lower extremity blood pressure. So we do that on all our patients. 15 lead EKG, we do right there in the office and review with the family. The history and physical exam, one of the most important parts of what I do, but probably one of the parts that takes the least amount of time. I can usually find out a lot of what is probably going on with the patient just by a really good history with the family. Then after that, additional diagnostic testing like an echo, which we do right in the office, which I have always felt very strongly about, that doing the echo right in front of the parents and right in front of the patient, and going over with the results with them right there in the office is a crucial part of a visit, which goes right along with family counseling and planning. If there's a patient that needs to go see Dr. Ferns or maybe needs to be presented in surgical conference for a possible cardiac repair, that's where I will go over that with the family afterwards, and then I'll start to make phone calls to folks back in Jacksonville. Then I do a full consultation report and send a copy of it back to the referring physician, wherever they are, Valdosta, Perry, Tallahassee, any of the referring areas here. That the pediatrician will get a consultation report within about at least an hour, probably from when the patient was done being seen. And then we make arrangements, maybe to have the patient go over to Jacksonville for a heart cath, or see Dr. Ferns for an EP study, or to see Dr. Schillingford in his clinic for a surgical referral. These are some of the more common tests that we do both in our office, and sometimes we actually mail out things like heart monitors to the patients. A complete echo with Doppler and color, which we usually take about 80 or 100 images from start to finish and go over those with the family and be able to diagnose if there are any abnormalities or not. Holter monitors, which we also put on. So Cynthia, our echo tech, is fantastic. She not only does the echoes, but also puts on the Holter monitors. And we actually mail out the event or loop recorders. Dr. Ferns helps me coordinate that from Jacksonville. So the family gets those at their house and they put it on, and then they mail it back. Treadmill tests we will occasionally do at TMH. So we'll schedule a time there. I'll go over to the hospital and monitor the patient running on the treadmill. We'll look for any abnormalities on EKG or echo and go from there. Fetal echo, like I said, Cynthia is fetal certified. And so when we have our clinic up and running, we'll be doing fetal echoes right here in our Tallahassee office. CT and MRI, which are higher quality imaging of the heart, we set those up to be done in Jacksonville at Wolfson Children's Hospital. And then, like I mentioned a couple of times already, heart catheterizations, either with Dr. Ategi or Dr. English, and EP studies with Dr. Ferns, we arrange and set up for them to go to Jacksonville for. First topic that I wanted to sort of briefly talk about a little bit tonight is probably the most familiar to most of you, but it's heart murmurs. It's by far the most common reason that children come to see me. And a very common misconception that I end up explaining to a lot of parents. Many people associate the word heart murmur with something bad or something being wrong with their child's heart. And I've many times had parents almost in tears because their child has a heart murmur. And when it turns out there's actually probably nothing wrong with the heart. So a murmur is just a sound. It's literally nothing else but a sound. And a heart murmur is just a sound from the heart. Many, many times that is just a normal sound. So that's something that I have a conversation with parents about all the time, explaining to them that, we have tests that we need to do to be able to diagnose abnormalities with the heart, but the presence of a heart murmur is not necessarily a bad thing. We grade those on a 1 out of 6 to a 6 out of 6 scale. And some of the common words that I use to describe heart murmurs are words like vibratory or musical, which those are innocent sounds, harsh or blowing, low, medium, or high pitched. Those are all sort of descriptors of pathologic heart murmurs. And then short, long, holosystolic, which is pathognomonic for VSDs, and ejection murmurs, which usually come from valvular problems. And I've always loved this picture on the right-hand side of the screen here. That's a picture of the ventricular septum. And if you can sort of visualize that in 3 dimensions, you can tell that the ventricular septum is not a straight plane. It's not flat like a wall or a piece of paper. It actually has a lot of 3-dimensional architecture to it. So there are literally hundreds of places that children can have VSDs. And there are actually 4 different kinds of VSDs, but many people think that VSDs are always in the same place, and they're not. They can literally be just about anywhere. Up to about 30% of infants have murmurs, which most often are innocent, and anywhere from between 30 and 50% of kindergarten age children have murmurs at some point up until then. But only about 1% of infants actually have congenital heart disease. So the actual number is 8 out of 1,000. So if you do the quick math, if only 1% of children have heart disease, but up to about 50% of children have murmurs, that means about 98% of children with murmurs actually have totally normal hearts. And that's a point that I try to stress to parents. The association of murmurs with congenital heart disease is higher in infants and sort of decreases as children get older. So this is something that I observe. More often we have babies who come in for murmurs, and we typically treat those with a little bit more urgency. We like to get them in younger to be able to identify congenital heart disease problems that may need surgery as a baby. But lots of times when you pick up murmurs for the first time in a teenager, for instance, that you got a much lower chance of actually having some sort of congenital heart problem that's gone undiagnosed for 10 or 15 years. And murmurs in athletes require special consideration. This is something that I do lots and lots of evaluations for, like in the fall for football season or basketball. But right now has become more common with COVID, because there's a lot of clearance questions that are going on with athletes who want to get back on the basketball court or get back out to playing soccer, and they've tested positive. So I'll have a slide about that in just a minute. The most common childhood murmur, many of you probably know, is something called a Still's murmur, or a functional heart murmur. It's caused by, if you look at this echo picture on the right-hand side of your screen, now you have to think upside down because this echo image, the heart is inverted. So the ventricles are on the top part of the picture and the atria are on the bottom part of the picture. But you can see that there's an arrow pointing to a bright white structure there called a cavitary band, or a false tendon, as some adult cardiologists like to call it. And that literally just makes a vibration. So we call Still's murmur vibratory murmurs or musical heart murmurs. And I describe them to patients as like strumming a guitar, because I play the guitar, so it's easy for me to understand. The most common actual congenital heart disease in the US is a bicuspid aortic valve, which about 3% of people here have. The reason why we don't call it the most common heart problem that we diagnose is because many people with bicuspid aortic valves are undiagnosed, and they often don't find them until they're adults. VSD actually is what we call the most common, and it makes up about 30% of what we see in congenital heart disease. And congenital heart disease is found in about 10 to 20% of the children that we evaluate for heart murmurs. Functional heart murmurs, I sort of briefly mentioned that word a minute ago when I was talking about Still's murmurs, but they can literally be anywhere in the heart or around the heart, in the arteries or veins that connect to the heart, and they're literally just a sound that's created by the blood flow in and around the heart. So PPS is a word or a group of letters that I use a lot, especially in babies. And the name is short for peripheral branch pulmonary stenosis. I don't necessarily like that word all that much because it makes it sound like there's a problem, but that's actually a normal finding. And that's what's depicted in the echo image that you see on the screen here. The bright spot where the blood flow turns from blue to orange is actually the right pulmonary artery branch where it takes off. And the reason it gets bright is because the flow of blood accelerates there, and that's just a product of babies being in little tiny packages. So little tiny babies have little tiny arteries, and the flow accelerates and it makes a murmur. Now, as little tiny babies become bigger babies, the flow slows down and you don't hear the murmur anymore. So that's a PPS murmur, and that's the most common murmur that we hear in the newborn babies in the nursery. Tricuspid regurgitation actually is also quite common. I had a hospital nursery consult from a local pediatrician here, actually just yesterday, said he heard a murmur. And when we got the echo on the baby, it was tricuspid regurgitation that I think he was hearing. So that's a little bit more common in newborns because of the high pulmonary resistance in the lungs after babies are born. And that goes away as their pulmonary resistance drops as they get older. Pulmonary flow murmurs, you can literally just hear blood flow in the pulmonary artery because it's the most anterior part of the heart. The main pulmonary artery is literally right under the chest wall. So when you put your stethoscope there, that's the closest thing to your stethoscope. So sometimes you hear the blood flow there, and that's normal. And then venous hum, you hear it mostly in older kids, but when you have them lay down and you have them turn their head over to the left, you can sometimes hear superior vena cava flow here, and we call that venous hum. Moving on to the second topic that I think is pretty important and I see a lot of is syncope and dizziness. Obviously, by far the most common is a non-cardiac issue, which is vasovagal or neurocardiogenic syncope. And that is most common in teenagers, and I do tend to see it more in females than males. But some other things, other than not drinking enough, that can cause vasovagal syncope is getting poked with a needle, having blood drawn, seeing blood for the first time. I'm guilty of that. I passed out the first time I saw blood in medical school. So I have had vasovagal syncope before, and it's not fun. So I do see quite a bit of this, and have to have lots and lots of talks with patients about adequate hydration. Syncope, obviously when they send their patients to see me, we are trying to identify cardiac reasons for syncope, although less common than vasovagal syncope, equally or more important to find. So when we do EKGs, we are looking for arrhythmias like long QT syndrome or Brugada syndrome, doing echoes, looking for things like cardiomyopathies, whether it be dilated cardiomyopathy with poor function, or hypertrophic cardiomyopathy with a big, thick left ventricular heart muscle, and very, very tall amplitude on an EKG. And that sort of cardiomyopathy, especially if the syncope occurred with exercise, would be very concerning. So the history of the symptoms is very important in these patients. Getting a baseline EKG, even if it's done in the primary office, that's a great place to screen for things like this. And then once they come to cardiology, getting an echo. If we think there's an arrhythmia, then a Holter monitor or a loop recorder. And then if we find some abnormalities, then ultimately a referral to EP over to Dr. Ferns. And I've had a few of these in the past year that Dr. Ferns has identified things like Wolff-Parkinson-White or long QT syndrome, and she's done ablations for us. And we've had athletes who were held out of sports because of arrhythmias who now are back competing. And that's our goal, to make life as normal as possible. All right, slide. There we go. Vasovagal syncope, just a little cartoon here on the right about the vagus nerve, the cause of many, many people's problems. So some people's vagus nerves are extremely oversensitive, I guess is one of the ways I describe it sometimes to parents. Overstimulation of the vagus nerve, which travels down from the brain, down below the aortic arch and down to the sinus node, and then further down to the GI tract in the stomach. Overstimulation of the vagus nerve can cause bradycardia because it immediately slows down the sinus node and slows down the heart rate. It also causes vessel dilation in the periphery. So you have a temporary drop in blood pressure and you faint because of the lower blood pressure and perfusion to the head and the brain. Things like changing positions. So if you get up in the morning and you get up too fast, and all of your blood flow has been pooling in your stomach and in your legs all night, and you jump up, your blood pressure drops, and you faint. All of these are vasovagal syncopal episodes. And also, just like you were told in church when you were young, don't lock your knees when you're standing up in church for long periods of time. Same sort of issue. Your blood pools down in your legs and you don't get enough venous return to your heart, and your blood pressure drops and you pass out. Like the little girl here is doing, the key to vasovagal syncope prevention is hydration. So I ask all of my patients, how much do you drink? And they say, oh, I drink a lot. And I say, okay, well, how much is a lot? How many ounces per day do you drink? And probably only 1 out of 100 of them actually count it and know the answer to the question. So it starts with counting how much you drink, using a bottle or a cup that clearly delineates how many ounces you're drinking, and then shooting for a minimum of about 60 per day. And in athletes, I actually tell them closer to 100. They can also add salt in their diet. I've even had patients who've come in, I think yesterday, a young lady who was taking salt tablets because she has POTS. So lots of different ways to get salt into your diet, which helps you retain fluid. And then lifestyle modification and abatement is actually probably the biggest key as well. If they feel dizzy, they need to sit or lay down. And that's the first thing I tell them. Prevent yourself from passing out by go ahead and just laying down. And typically the symptoms will get better once gravity is no longer a part of the equation. And then ultimately, if supportive measures like drinking and adding salt and laying down when you're dizzy don't work, then I usually have them come back for a follow-up appointment, and we talk about Florinef or Midodrine, which are both medications that can help with vasovagal syncope or autonomic dysfunction. Syncope in athletes is the big deal. That's what's on the news. That's what happened here in Tallahassee about a month ago at the FSU basketball game. It was in the news everywhere. It was on ESPN. In fact, that's how I found out about it. I was at home watching TV, and they said this thing had happened here in Tallahassee. And what you see here in the picture, there's been a couple pictures that I've showed already of my son playing soccer. I'm learning a lot about soccer because I never played soccer, but he's all about soccer. So there was a very famous soccer player here in this picture that you see named Fabrice Muamba, who had a cardiac event during a soccer game just a few years ago. I think it was 2012. And had an undiagnosed cardiac condition. And that just sort of further proves that you can be a college basketball player, or you can be one of the best soccer players in the world and have these undiagnosed cardiac conditions that can cause cardiac arrest. So syncope in athletes, it's a big deal. That's what I'm trying to say. And it requires very thorough cardiac evaluation. Not only to rule out arrhythmias, but structural and functional heart disease, things like cardiomyopathies. And often, like in both of these athletes that I just talked about, they're often asymptomatic, very healthy, good athletes, and their first symptom that they ever have is collapse. Just a brief word about arrhythmias. The EKG drawing that you see here on the right is actually one of my favorite arrhythmias. I'm sure most of you know exactly what it is. That's a pathognomonic EKG of a wide QRS and a delta wave, consistent with WPW or Wolff-Parkinson-White. Any patients that come to see us for palpitations or an irregular heartbeat, that they're primary noticed on an exam, syncope, dizziness, all of these things, we're always worried about ruling out arrhythmias. So the family history is important. If you have a family who many people have long QT syndrome, and they have a new baby, you obviously want to screen that baby to make sure that the baby doesn't also have long QT syndrome. Also medication histories. There used to be a website called longqtdrugs.com, because there are some medications that can cause long QT syndrome. So knowing what medications your patients are on can play a role if you get an EKG that looks suspicious. We'll obviously get an EKG and an echo in the office, and then depending on their symptoms, send them out with a 24-hour Holter monitor or a more long-term event recorder if we feel like they need it for their symptoms. And then depending on what we find, their follow-up and activity depend on, what their diagnoses are. Certain patients, like for instance with Wolff, Parkinson, White, can continue playing sports unless they have a syncopal event during sports, at which time we would halt their participation and investigate it further. Send them to Dr. Ferns. They can have an ablation for Wolff, Parkinson, White, and then they can go right back to participating in sports. Myocarditis and cardiomyopathy, those are a special case. So, I would typically run into a patient who has something like this, probably in the hospital. Myocarditis patients can get really sick and they can be in the ICU with very poor heart function and needing inotropic support. There is a wide spectrum of things that can cause cardiomyopathies and myocarditis. Unfortunately, a lot of times we don't find an answer for why children have cardiomyopathy. Sometimes they're born with it. Sometimes it's infectious. Sometimes it's inflammatory. And then sometimes it's hypertrophic, which is what we worry about in the athletes. So the definition of heart failure is the inability of the cardiac output to meet the metabolic demands of the body. So if your ejection fraction of your heart cannot produce enough cardiac output for your metabolism of your body, you literally fall into heart failure. And these symptoms can be patients who are lethargic, patients who try to participate in sports, but they get very short of breath and they can't keep up like maybe they could a year ago. Things like eyelid edema or pedal edema, syncopal episodes during exertion or arrhythmias. And sometimes these patients can actually have sudden cardiac death, which is one of the reasons why patients who have myocarditis, it's recommended that they be on bed rest, but they certainly can't play sports for a minimum of 6 months after they're treated. And they obviously need a complete cardiomyopathy workup, not only imaging studies like EKGs and echo, but also serum lab work to try to determine the cause of the cardiomyopathy. Just a quick note about COVID-19. Like I mentioned, I'm sure this is happening everywhere, but I know it certainly is happening here in Tallahassee. We have a plethora of, seems to be teenagers right now who are playing basketball. Other sports have had some wrestlers who may not necessarily have been all that sick, but they tested positive for COVID at any point in the past few months. And they're athletes, and there's a lot of cause and concern about safe return to play. So this is an excellent paper that I'm using, on an almost daily basis in my office to determine if and when kids can go back to sports. And it was written by actually a classmate of mine in medical school, Lanier Jackson at MUSC in South Carolina. Great guy, really great paper. If you haven't seen it already, just maybe jot down or take a picture of the link here, and you can find it anywhere. And it has a really nice algorithm in it as far as what patients need to be referred to cardiology and which patients can pretty simply go back to playing without any further cardiology investigation. Moving on to chest pain, the third topic that I wanted to talk about tonight. It is a very frequent pediatric and more commonly adolescent complaint. Now, numbers wise, the good news is that cardiac causes of chest pain are by far the least common. Musculoskeletal is by far the most common. And pulmonary and GI make a small percentage in the middle somewhere. So we do lots and lots of cardiac workups for chest pain. And in reality, I have lots and lots of conversations about asthma. Workup includes a good history of the symptoms, the family history, obviously a good, not only, but, pulmonary, but also cardiac exam, an EKG and an echo, and sometimes if it happens with exercise, a treadmill test. Costochondritis or a musculoskeletal chest pain is the most common. The name costochondritis literally just means inflammation of the ribs and cartilage. And somewhere around 80% of chest pain in kids is usually due to this. It's often caused by sports, which is probably why I see it most often in teenagers. If it's the boys, it's typically they're weightlifters and they're doing bench presses and they're banging a lot of heavy weight on their chest wall, and all of a sudden they have chest pain and can't figure out why. In the younger kids, it's the ones like my kids at Killarn Lakes who have a 25-pound book bag full of books, and they have these two heavy book bag straps, and it's pulling on their chest wall, and before you know it, they have some chest wall pain. So those are all things that I ask them. You know, I ask them about sports. I ask them about going to school and carrying heavy book bags. And the thing about this versus exercise is costochondritis is actually just as common when you're at rest as it is when you're exercising. So that's a key thing that you can use to delineate between the more worrisome kinds of chest pain. And, you know, a lot of times kids will say, yeah, it bothers me when I lay down, or it bothers me at night when I'm trying to go to sleep. And they usually describe it as sharp or stabbing. And if you point, or you ask them, you say, hey, can you point and show me where it hurts? They'll usually point to a rib joint somewhere. And we treat these with things like Aleve or ibuprofen. Seem to work really great. Pulmonary causes, like I mentioned, I feel like I'm still pretty well versed in asthma, even 6 or 7 years after my pediatrics residency, because I see so much chest pain. You know, we talk a lot about exercise-induced asthma and bronchospasm, and I try to really hammer home the point that asthma can be just as deadly as heart issues. So taking really good care and control of their asthma is really important. And usually they're going to notice this chest pain with exercise, if it's exercise-induced asthma. And they, instead of the sharp sort of stabby kind of chest pain, they actually describe it as more of a tightness. And they'll sort of show that it's like a band over their entire chest. And that also can lead to some chest wall pain because the lungs are full of air and they're having trouble getting the air out. So everything's hyperinflated and it hurts the chest wall. And obviously bronchodilators are the treatment for this. So I will often recommend that they use their albuterol inhaler before they exercise. Less common pulmonary causes, things like spontaneous pneumothorax. Those are, you know, outliers, but something that you may see. Obviously, you get a chest x-ray for that. Pneumonia actually can cause a lot of chest pain, especially if they cough a lot, and pleurisy. GI causes, I do occasionally run into some things like this when I'm talking to patients. Reflux, reflux is probably the most common. Also esophagitis. I had a patient yesterday with eosinophilic esophagitis. And after we did all their cardiac studies, we finally decided that we thought it was the esophagitis that was causing the chest pain. And in younger kids, especially like 2 and 3 year olds, foreign bodies, putting things where they're not supposed to be, and pancreatitis, pain that goes to the back. Sometimes you ask them, you know, what kind of food do you eat? Does it happen when you lay down to go to sleep at night? And a lot of them will say, well, yeah, I like eating Mexican food or spicy food or peppers or hot fries. Seems to be a popular thing here in Tallahassee. And they describe it as squeezing or burning, which is a little bit different. Each one of these types of chest pain is described just a little bit differently. And then the treatment is just avoidance of the triggers. If eating spicy food makes your chest hurt, don't eat spicy food. Or sometimes you can give them a trial of acid reducing medications. And sometimes I'll, you know, recommend that people get over the counter ranitidine to see if that helps. And sometimes they may need to go see a GI specialist, which we can actually help them with as well. Cardiac chest pain. So this is the quote unquote bad stuff. This is the stuff that I'm really trying to find, but we hope that we don't find it all that often. Chest pain during exercise that results in collapse or syncope or dyspnea on exertion. Those are all reasons, you know, to get a full cardiac workup. It's often undiagnosed. A lot of these patients don't have any previous symptoms. And where these patients get into trouble is that when they have hypertrophic cardiomyopathy, like you see in the drawing there to the right, the LV is so hypertrophic that the cardiac output during exercise is not enough to perfuse the coronaries. So the coronaries become ischemic. You devolve into ventricular arrhythmias like ventricular tachycardia, and that usually devolves into ventricular fibrillation, and that's when you collapse and arrest. This is one of my favorite drawings and one of my favorite cardiac issues that I've found, I think, 3 times in the past 5 years here in Tallahassee, anomalous coronary arteries. So most people, when they hear anomalous coronary, they think about Al Kappa or anomalous left coronary artery, which we usually find in babies. But this particular kind of anomalous coronary that I'm talking about is the kind that goes undiagnosed until usually you're a teenager and you're playing sports and you're having chest pain only when you play sports. And that is the key differentiating feature between this kind of chest pain versus, like, say, costochondritis. So just a few months after I moved here to Tallahassee, I had a young man who was like an early teenager who played tennis. And he only had chest pain when he played tennis. And he would sit down to rest when his chest would start hurting and the chest pain would go away on its own. So what I ultimately found with echo was that he had an anomalous coronary artery. And in his case, it was his right coronary artery, which was actually traveling all the way from the left side of his aorta from the left coronary cusp. And that's what you see in this drawing. So in a normal heart, the left coronary artery comes off the left cusp of the aortic valve, and the right coronary artery comes off the right cusp. And then you have the posterior cusp, or the non-coronary cusp, where there is no coronary artery. But you can have two variations of that. You can either have the right coronary that comes off the left side, or you can have the left coronary that comes off the right side. And in either one of those scenarios, you get into trouble because, as you can see, that right coronary travels right between the pulmonary and aortic valves. And so those are both in arteries, and arteries are pulsatile. And when you exercise, the aorta starts to pulsate. And what that does is squeezes that coronary artery, and it causes vasospasm and ischemia. And it's sort of like angina, but in kids. So that's what an adult would feel if they had an anginal attack. This is angina in kids, basically. And so what you do is you refer that kid out to get a CT scan of the chest, where they can really delineate where this comes from, and the surgeon can actually go in and reimplant the right coronary back over to the right side, or the right cusp. And it works great. They go right back to playing tennis after that. Just a quick picture here of a pericardial effusion, which many of you probably have seen in practice. Just inflammation or fluid around the heart. Here's an echo picture where you can see a very large pericardial effusion, probably one that needed to be drained with a needle. That can cause significant chest pain. The history for a patient like this is that it's a tearing or a burning pain that feels better when they lean forward, and it hurts worse when they lay down. So a lot of times I'll ask them, do you sleep flat, or do you prop yourself up on pillows? And many times kids with pericarditis or pericardial effusion will say that they have to prop themselves up on pillows. They have a very harsh pericardial friction rub. So when you listen, you hear a real harsh, kind of like a sandpaper sound. And once we get an echo, we basically know what this is, because we can see the effusion around the heart. And if it's an emergency, if this kid's in Dr. Gale's ICU in Jacksonville, the cardiologist or an interventional radiologist is going to come in and drain this with a needle. If it's non-urgent or non-emergent, it's in your office, you can try ibuprofen or steroids, and typically that will help resolve the fluid. So that's my last slide. Here's a picture of my family. A couple years ago, we caught a couple of fish. My son loves to fish. My daughter obviously does not. You can see that she did not like the fish, and she wanted to get really far away from it. So this is one of our favorite family photos, and one that we have framed in our living room. So that's all I've got. I really appreciate everybody that participated. It's probably one of the best turnouts that I think I've had for a talk. So thank you all.